I give part of Ed's introduction before when we were in class before, but I met Ed Mullen when I was 21 years old and I was a doctoral student. And at that point, Ed was already very, very famous, and then was working in the area of evidence-based practice, and was one of the articles I remember reading as a graduate student was Developing a Personal Model of Practice, which was about searching the evidence and putting together for yourself a model of practice that was coherent and that was evidence-based. And I probably used that article for the first 15 years I taught. But since we have Ed here, I thought it was a wonderful opportunity to have God himself come and give you a fundamental lecture on evidence-based practice. So thank you for coming.
Thank you, Andre. And I've known Andre over the years, and she's been a great contributor to the research-based practice and evidence-based practice movement as well for many years. So I feel fortunate to be able to have this opportunity to work with Andre again and to talk with you about evidence-based practice. Andre says that I've been working on this for many years. Yeah, the downside of it is that it sounds like I'm stuck, right? You work on something that long for so many years, but it actually has evolved quite dramatically. And those of you that are in my other class know something about the background, I'm sure, of evidence-based practice. Could I see a show of hands? How many of you already know what evidence-based practice is? All right. So what I'm going to do today is build on that foundation, and I prepared a PowerPoint which I'll use. I see we don't have the remote here, so I may end up getting stuck behind the podium. And here it is. Let's see if the remote works. So I'm going to basically follow this PowerPoint. I outlined it for this purpose. And what I said to myself was, well, what I'd like to do is basically rethink what are the key concepts that make up evidence-based practice, and secondly, what are the key steps involved in being an evidence-based practitioner. And then I wanted to say something about the philosophical assumptions underpinning this approach to practice, which are important. And lastly, identify some of the advantages of evidence-based practice and some of the issues before it. So how does that sound as an agenda? And this is not cookbook. This is not out of a text. It's something that I sort of put together for this, and I want to kind of trace some of the ideas for you as we talk. This PowerPoint is available if anybody wants it, and I guess this is videotape, so this tape will be available as well. Now, challenging technology. I really got burned yesterday. I'm scared of this thing. But let's see if this will work. All right. As you know, you can hear me all right with this? Is this projecting? Okay. As you already know, I'm sure, evidence-based practice began in the field of medicine at McMaster University back in the 80s and early 90s. And the idea there was that some of the folks training residents and interns at McMaster University in medicine observed that very little of the published journal article reports of new findings in medicine were being read by the doctors in training. That was one key issue. The other key issue that was factoring into their concern was that much of what was being read, and surely what was being practiced, was not based on what was known to be the best available evidence. And that was a concern. So these folks at McMaster University, much as if we were here today in this school, decided we needed to do something about your education. And they evolved and proposed an approach to training that was called research-based practice, which was quickly shot down by the rest of the faculty, believing that practice should be much broader than just based on research. Secondly, they proposed, well, let's call it scientifically based practice. And the collective faculty sitting around said, what do you mean? We're not scientific ourselves now? Imagine saying that to a group of distinguished faculty. So then, finally, Sackett and Guillet and others proposed, what about evidence-based medicine? And that went down. Everybody said, okay, evidence-based medicine seems to be okay. How did they define it? The first definition, and I found an appropriate little icon for PowerPoint for the medical doctor. The first definition you've seen, I'm sure, before. It's frequently cited. Evidence-based medicine has been defined as the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. That was Sackett, one of the key founders of this, and back in 1996, when this was first really officially defined. Now, make note of this definition. It's nothing like the definition that we're teaching you today that talks of what's missing here. Anything strike you? Yeah.
There's no practice with them?
There's no practice experience. There's no, where's the client? Where's the patient? Patient preferences and values, and so forth. So we're going to trace how this then evolved. Realizing the problems with that, in 2000, Sackett proposed this definition, which is widely quoted now. And here you see, it says, and the integration of best research evidence with clinical expertise and patient values. Wow. I mean, those look like words on the boards, but those are important. We've all of a sudden popped in patient values, the patients there, and practice expertise and experience. That's a big change. What is the most recent definition, and how does it differ? The most recent definition is coming from the same current version of the Sackett book, which is sort of the Bible of evidence-based medicine, called evidence-based medicine. But now he's stepped aside, and the first author is Strauss. And this is the current definition. Evidence-based medicine requires the integration of the best research evidence with our clinical expertise, the therapist, and our patient's unique, that word was not in there before, unique values and circumstances. Is this beginning to feel a little bit better? So that's kind of where evidence-based medicine is right now. What about what evidence-based social work, as I said, is an adaptation of evidence-based medicine. That's why I'm going through this background in terms of how medicine has evolved. And this is parallel with the health fields, it's very much in nursing and other health fields as well. The issue is, what is best research evidence in that definition? And Strauss, again, is saying that best research evidence is valid, clinically relevant research from basic sciences of medicine, like pathology, anatomy, an understanding of the disease process, and so forth. That's the basic sciences of medicine. But look at here, something important. While that's recognized as good information, the emphasis is, but especially from patient-centered clinical research, patient-centered clinical research. That is, research that is conducted with real patients, where the focus is very much on the context of the patient. That's quite different than basic research about disease processes. And that research is about diagnostic tests. This isn't just about being effective and being cost effective. It's about as well being able to diagnose accurately in medicine. Prognosis, being able to use evidence that's going to be correct and valid about the natural outcome of certain processes or problems that we're concerned about. In our class yesterday, for instance, we heard a video that focused on the issue of a patient who had blockage of an artery that was going to the brain. And the issue was, should this 80-year-old asymptomatic patient receive surgery to clear the artery, which was blocked, what, 64%, 68%? And the senior surgeon said, yes, definitely. The patient's at risk for a stroke if we don't do this. Okay, what was his evidence for the risk of stroke for an 80-year-old man with uncomplicated symptoms, no symptoms? So this would say, before you jump to that conclusion, let's bring to the table the evidence about the prognosis so we know what we're talking about. Diagnostic tests, prognosis, efficacy and safety of therapeutic, rehabilitative, and preventive regimes. So it's really cutting across the board, prevention as well, and that's very important in public health as an example, and it's important for us. What is clinical expertise in this definition? Clinical expertise is the ability to use clinical skills. This is saying you as clinicians. It's your ability to use clinical skills and experience, your experience, the older you get, hopefully the more you'll have, to rapidly identify each patient's unique health state and diagnosis, individual risks and benefits of potential and the benefits of potential interventions, and their personal circumstances and expectations. Now, there have been some arguments that evidence-based medicine and evidence-based practice mechanizes intervention. It takes you, the practitioner, out of the equation. My argument is just the opposite. This is saying an awfully lot that you have to do. It's all going to have to come together with you as the professional. So this is a broad view of clinical expertise in the context of evidence-based medicine. And what do we mean, the other part in that definition, by patient values? We mean unique, singular, preferences, concerns, and expectations each patient brings to a clinical encounter and which must be integrated into clinical decisions if they are to serve the patient. Wow. Does that sound like social work? That sounds very much what social work stands for, and it's very much what we hope social work would do. If we think of the video from yesterday, the audio, remember the last session was when the social worker convened the doctor, the rehab person, the nurse, the daughter, right, who had power of attorney. And they brought the evidence that they had collected to bear in a group discussion with the daughter, and the daughter very much brought in the father's preferences for no heroic interventions, and what dad would want. She brought that to the table, and a decision was made. But it was the social worker who, as the evidence-based social worker, took responsibility for making this process happen. Okay. And lastly, I think, by patient circumstances, we mean their individual clinical state and clinical setting. So in the example yesterday, this was a hospital situation where the father had been brought in through emergency services. He was somewhat disoriented, but able somewhat to participate a little bit. So all of that sort of thing has to be taken into account. What would happen if he came in and he was very oriented and very capable of making his own decisions? Who would be the patient? Who would be representing the patient then? The social worker would need to decide he's capable of representing himself, and all of this would have been done with him. So you have to take into account clinical state, and that would be an example. Okay, lastly, you see how this is evolving? And it's not going to stop here. Don't reify these concepts. They change, they evolve. You can probably improve on some of these definitions yourself as in social work. That's what we're struggling with right now in social work. So now we got the newest. This is a picture of the newest model, which we just looked at. It's basically a Venn diagram, clinical state and circumstances. Sometimes a picture helps you to think about this better than a word. So the circle for everything you need to think about in terms of the client or the patient's clinical state and circumstances, client preferences and actions, right? The research evidence. We haven't said much about that, but we're kind of taking that for granted. That research, you are going to be responsible as the evidence-based practitioner with your team of collecting the evidence, as we saw yesterday in the tape. They did a good, quick job of doing it. It's getting easier and easier. And bringing that together with, you see how far this has come from the early 1996 definition. Now you have the clinician right there bringing this all together, and that's clearly what we saw yesterday, or heard yesterday in the tape. Okay, so you've got a good sense of what how evidence-based medicine is conceptualized currently. And if you run into a doctor or a nurse out there right now and they've studied this and they're practicing it, they would be comfortable with that view. But now we are social workers. So what does this mean for us? Nursing has added, I'm working with an interdisciplinary team, I'll mention it later, but the nurse on the team who has brought an important variation on this definition from nursing that stresses context much more and qualitative research much more. The public health person on the team has stressed very much the complexity of environment and has argued for an ecological framework that lays over all of this. Sound familiar? Very much at home. So, what is social work doing? Well, we've been busy, haven't we, Andre, developing a definition of evidence-based social work that fits the profession's context. Been much discussion in the last 5 years, I think about 5 years. So what is evidence-based social work? We're going to leave medicine behind now. That's a picture of my house in Vieques, looking off into the hills of Vieques. But I thought it would be a good backdrop to say something is either setting or something is rising. But perhaps we have a definition of evidence-based social work that's coming forth, and something else maybe in sunset, I don't know. Sheldon in Britain, the people from the UK have really been ahead of everybody else. The Canadians and the folks from the UK have been very much further along in terms of evidence-based policy, especially, and evidence-based practice. And they've really been leading the way. Social workers in the United States are sort of dragging along. And in Northern Europe, they're coming along as well. So Sheldon is out of England, and this was his first definition. I wonder what you think of this. The conscientious, explicit, and judicious use of current best evidence in making decisions regarding the welfare of service users and carers. Have any trouble with that, given the evolution in medicine? Yeah.
It's still not really including the client or the patient in the decision-making process.
Exactly. And so the patients aren't there. Where's what else is missing?
Specificity.
It's very general.
The practitioner's expertise.
Practitioner expertise. So Sheldon was much criticized. He's a great advocate over the years of using research in practice, but he's been much criticized for that definition. But you see, he was really building on the first definition of evidence-based medicine, which is pretty much what all of these things are. Gibbs, who some of you know of, Leonard Gibbs, who is the person who has contributed the most to evidence-based social work and has taught this the most, and who just recently passed away, proposed this definition. Look at here. Placing the client's benefits first. How's that to start? That wasn't there. Evidence-based practitioners adopt a process of lifelong learning. Well, that wasn't in those other definitions. So we're in this for lifelong learning? You mean I'm not going to graduate after 2 years and know everything? Two important additions. Actually, he adopted these from some folks in medicine, but they didn't end up in the definition. That involves, what does this learning involve? It involves continually, as we engage in practice, asking questions of relevance to the client. So it involves continually throughout our professional lives posing specific questions of direct practical importance to clients, That decision yesterday in the tape of whether or not to have surgery for a blocked artery was a practical question, not theoretical. Searching objectively and efficiently for the current best evidence relative to each question, and then taking appropriate action guided by the evidence. All right, so that's Gibbs's current definition. So we can, again, go back to that diagram and borrow from one of our colleagues, Aaron Slonsky, who adapted this framework for his work in which he is looking at child abuse and neglect. And he's concerned about how do you make valid judgments as a clinician about risk of harm and then take action based on that assessment. So he's using it, and he's saying, as an example, there is a cycle of evidence-based practice. In that case, you would go to the current best evidence box, and you would look for actuarial risk assessment data about clients like yours that tells you something about their risk for abuse or neglect. Borrowing from Eileen Gambrell in Berkeley, he's saying that you as a clinician, as a social worker, would do a contextual assessment, and that would involve studying your client. What is the problem situation? What are the circumstances of the client? What are the strengths? What are the weaknesses? What are the client's preferences and actions? What are they involved with? So you would explicitly search that out as part of your process. More research evidence, other valid assessment measures that would maybe, what is a valid instrument that's out there that I could use with my client to assess their risk of harm? I once worked in this at Chapin Hall at the University of Chicago, and we tried to develop expert systems that clinicians could use to assess risk with individual cases. That didn't go anywhere. What do we know about effective interventions to deal, in this case, with risk of harm? Maybe work with the family, etc. Is what I'm learning from the research evidence appropriate for this client? So here's the circle. You're finding the evidence, you're bringing it back, you're melding it with the information that you've already gathered in your study process about the client in your contextual assessment, and then you're asking yourself, and you're engaged with your team and with your clients, is this best method of assessment, or is this effective service that's available appropriate for this client? And part of your contextual assessment is, and as we saw in the audio yesterday, coming back to the family, client's preferred course, or at least willing to try. Is the client, in the case of yesterday, the daughter, willing to try the surgery, which the evidence suggested? She said no. Even though there was, what, a 1.9% difference or something like that, you would need 50 patients to treat before you could benefit one based on the number needed to treat. It came back to the client's preferred course, which was to not do the surgery and then to move on to the next question about what is the best type of nursing home, right, to place the client in. And she concluded from her evidence search that a nursing home that used, was it reality therapy? Huh? Reality-based therapy would be the choice, and that's what she tried to arrange. And barriers. You may have a preferred choice, and in this case, in terms of the nursing home example, there may have been a barrier given your geography and your financial situation in terms of the ability to find a nursing home of that type. So, and cultural issues. They run through all of this. And of course, critical clinical expertise circle that brings all of this together. How are we doing for time, Andre? Okay. Now, I mentioned, okay, so we've got an idea of evidence-based medicine. We've got an idea of some of the beginning definitions of how this is being adapted into social work. We're going to see a little bit more on that. But now I want to step back and ask the question, how is this concept viewed more broadly, interdisciplinary, across disciplines? And I've been fortunate to be working with a group in the evidence-based behavioral health unit at Northwestern University School of Medicine, and they have a grant from the National Institutes of Mental Health to bring together representatives from various health disciplines to try to develop a common view of evidence-based, in this case, evidence-based behavioral practice, but we often set that aside and said we're talking about evidence-based practice. And to develop training materials for that, which are on their website. So what I wanted to do is pull from that work and take a peek at how we can view this currently from a transdisciplinary perspective. Does that make sense? Okay. This is the group, and when I told Bonnie Spring, who is the chair of this council that I'm working with, that I was going to mention this and use this stuff that has not yet been published, she said, fine, but list the people that have contributed to this first. So that's why I'm putting this up. She's coming out of, she's at the Department of Preventive Medicine, so she's coming at this as a behavioral psychologist in health. And Ross Brownson is a expert in public health evidence-based policy, and so we're getting a public health perspective. Me, Robin Newhouse, who's director of nursing practice, so she's bringing the nursing perspective. Jason Satterfeld, who is in the School of Medicine at University of San Francisco, bringing out sort of a medical perspective. And Evelyn Whitclock, who is in Kaiser Permanente Center for Health Research. And Kristen is library science, and she's bringing that perspective and contributing. So that's all by way of just attribution. What does the model look like? They're calling it a transdisciplinary view of evidence-based practice. Whew. The evidence is coming up there right away. The first circle that pops up is best available research evidence, right in the center. Client population characteristics, state needs, values, and preferences. So here, we're expanding this view to say, you're not talking about just individual clients, you're talking about populations possibly, especially from a public health and social work perspective, communities, families, so broaden it. Move it from the individual focus. Resources, including practitioner expertise. This is an interesting variation on the theme, looking at practitioner expertise along with other resources that might come from the agency. Woo! Something else now has popped right up here, and it vanished. Why did that happen? Decision making. So what they want to argue is that evidence-based practice is fundamentally a decision-making process, and that comes right into the center. And so this would be, the final element would be all of this is occurring within a larger environment and organizational context that has to be taken into account. So social workers should feel very comfortable that, in fact, we're working in agencies, organizations, we're working in communities, we're working in cultural variation, resources, and so forth, and all of that has to be added in, critically important, that may not be so, was definitely absent in the original evidence-based medicine framework. So that is the current working definition that cuts across disciplines, that everybody sitting around that table more or less could compromise enough to agree to. That would apply to their disciplines. I would still argue, I'm arguing, and this is not static, it's called a living document. I would argue for putting the practitioner expertise back in the center, and I would also argue that with the limited focus of the model of evidence-based practice being on decision-making. And I'm going to show you a slide where I present you my own sort of summary that you'll see it's a bit different than this, even though I can compromise with the team and work with this for now. But this calls it a decision-making model. And I can see where that's very comfortable. I mean, it's a way of making decisions, for sure. But is that all it is? So what is evidence-based social work practice today? Social work. Back to social work now. This is going to be my construction based on everything I'm hearing and what I understand and what I think. And it's a lot like what you've been seeing with some small additions. It is a professional decision-making process in which social workers and their clients, so I'm joining, and client can be broadly defined, together systematically make intervention choices using practitioner expertise to identify. Okay, so what I'm saying now is practitioner expertise. You are working with your client and you're using your expertise and you're working in partnership with the client. You're empowering the client to make some choices, to identify certain things. If you think of your client conditions, needs, circumstances, preferences, and values. In other words, it's not you, a social worker, sitting over here and looking at the client, running your diagnostic tests and so forth, and drawing conclusions. It's client and social workers working together to identify that. Together to identify the best evidence about intervention options, including potential risks and benefit likelihoods. To identify contextual resources and constraints bearing on intervention options. What's realistic, what's not, what's too costly, what expertise does your agency have, what can you marshal. Secondly, intervention choices refer to action options about how to assess client conditions and circumstances, right? Those of you in my class know that's one type of question you ask about, how to assess, how to provide services, how to intervene, and how, remember all this is with the client, and how to evaluate the process and outcomes of the service, of what you're doing. How are you going to monitor and evaluate together with the client what happens when you use all of this information? Clients, of course, can be cutting across the span up to populations, and best evidence includes findings from scientific studies as well as from other reliable sources considered to be of highest quality, strength, and relevance. I'm trying to broaden this to say if there aren't any RCTs, that doesn't mean you should fold up your tent and go home. What you are trying to do is understand what is the best information I can get my hands on and share with my client. Whatever that is, that's what you've got to go on. So that's why I'm trying to broaden this up to say it is best evidence. It's the best evidence that's available. And in some cases it could be pretty shoddy. But you're consciously, judiciously, and critically using what the best evidence is that's available. Using this decision-making process, social workers themselves provide the selected interventions, or they link clients to others who can provide the interventions. Now that's important, because one of our faculty members said to me in a committee meeting the other day, I'm not going to teach my students to do evidence-based practice. They're going to locate the best intervention for their client, and they're probably not going to have the skills to provide it. And they're just going to be frustrated. That's an important criticism. That's why I'm underscoring. It's where you yourself provide the intervention if you're capable or can get the training, or if it's the best intervention and it fits the client's preferences and values, and it's the intervention that should be received, then you need to link your client to an intervention source, a place, someone, somewhere who can provide that. It would be unethical, I would argue, for you to say, well, my agency doesn't provide it, I'm not trained to do it, so I'm not going to do it. I'm not going to do anything. You're going to link up to certain limits. So that's an attempt to deal with that issue, and it fits very much with social work. This is what social workers do. We often link and broker, and also in the long run you want to argue with your agency or your organization that if you've identified a best practice that the organization should be delivering, and this client that's coming in is bringing in a problem that's typical, then you want to argue with your administrators that they better bring in some in-service training to get the organization up to par to provide that sort of service. And that's an important role that an evidence-based practitioner can play. And they monitor and evaluate together. So I would wrap the definitions up by just with that last definition. And I want to, are we ending now or at 1? What do we do? We go at 1 or 10 to 1?
I think we can end at 1.
1 o'clock?
Is that folks okay? Good. That was my.
You're not asleep yet. I'm looking around. I don't see too many people yawning.
The room is warm, but I think we're fine.
We're fine. The room is warm. Okay, now I'm gonna jump to a different thing. You all now understand evidence-based practice pretty well, better than most faculty, I think. Wouldn't you say? Anyway, I'm going to jump to something now. What skills do you need? And I talk a lot in my class about competencies. And social work and other disciplines are moving towards a competency-based approach to training. It's less important what courses you take, as what's important is what competencies you graduate with. So what competencies do social workers need? And here I'm borrowing again from my Northwestern University colleagues in our work, you need assessment skills. Much of this should just flow with you. This is what you're already learning. But in a way, that's helpful because it's saying evidence-based practice is not something alien to what you're already doing. There are skills and competencies that you already have that you can use. Assessment skills, competency and appraisal of clinical and community characteristics, problems, values, and expectations, and environmental context. Competency to assess in an unbiased manner his or her own level of expertise, which comes back to what are you going to provide, and if you don't have the expertise, how are you going to get it? Who are you going to bring into the team? And this means expertise to your own expertise to implement the clinical techniques if you're a clinician, the outcomes, and you need some process skills. Not just assessing, but some process skills. You need competency in performing the 5 evidence-based practice process steps. You all know what those are, right? I think you do, but we're going to just outline them quickly. 1, a competency, evidence-based practice from a process perspective is thought to be involving these 5 steps. The ability to ask well-formulated questions, like in our video yesterday, the question was something like, I guess the focus on outcome was stroke, and the question was for an 80-year-old man with 64% blockage of this artery, will the surgery, as contrasted with no intervention, significantly reduce the likelihood or the probability of stroke? That was the question. So the ability to form a question is a first step. The ability to acquire the best available research evidence, that's your library search skills in particular, as well as your ability to consult with colleagues and read. The ability to appraise the evidence for quality and relevance, that's much of what we're going to be doing in our clinical class for the rest of the semester. Really being able to read critically somebody reporting the results of an experiment, or somebody reporting the results of a qualitative study looking at patient satisfaction. Apply the evidence by engaging in shared decision-making with those who will be affected, so the ability to intervene. And the ability to monitor and change your practice and your intervention based on what you're learning. So those are the process skills of evidence-based practice. And important, the fundamental skill that social workers need to have, as well as most helping professionals, communication and collaboration skills. Competency to convey information clearly and appropriately. This model places a tremendous burden on clinicians and practitioners to be able to effectively communicate to their clients and communicate all of this information. Competency to listen, observe, adjust, and negotiate as appropriate to achieve understanding and agreement on a course of action. And engagement and intervention skills. Competency in motivating interest, constructive involvement and positive change from individuals, groups, organizations, communities, and others who may be affected by the decisions. Good social work practice, engaging, motivating. And competency in the provision of evidence-based interventions which vary in degree of training and experience required. Oftentimes we put up this duality that evidence-based practice is a set of 15 interventions that have been proven by research to be effective, like ACT, or motivational interviewing, or multisystemic family therapy. Evidence-based practice is a process of what we've just outlined. We're going to call those proven interventions evidence-based practices, or in social work, evidence, empirically supported interventions, or something like that. And you need that. There's the picture. That's the picture. The 5 steps. And you probably can start anywhere at a different point in time. Is that clear? Is that a fair picture of what we've been talking about? Notice we put in, and this is from Northwestern University Group, I argued for a while that the first step in this circle ought to be assessment. Kind of putting on my social work hat, that we begin by assessing the situation, the contextual assessment and everything. Mm-hmm. So we agreed that we'll put it there as an arrow. And so you're always assessing. And you need to assess from the beginning before you ask your question. And then another way of stating it, Gibbs lays out the steps. He adds one initial one, which is become motivated to apply evidence-based practice. In other words, you've got to be motivated as a clinician to do all of this. You've got to be curious. You've got to be skeptical. You've got to want to do it. And you've got to engage your client in this as well. If you're not, then the rest of this doesn't follow. So that's why I've stressed with my students that actually a first step is identifying uncertainties in your practice when you work with your client. Because I think you have to be uncertain about something in your work with your client before you can move from there to ask a question. So what are the uncertainties? And this is important. I think I'll just touch on this. Yes, I've been asked to present a lecture in Switzerland in 2 weeks. They have a new school, they're calling it School of Social Innovation, School of Social Work. And they want to hear about evidence-based practice. And the first thing they want to have me discuss is what is the philosophy of evidence-based practice? What epistemology and philosophy is it based on? They're the German-speaking Swiss. That's important. Drawing from medicine, there's a nice chapter in the book, which I was cited here, Evidence-Based Medicine, How to Practice and How to Teach It. And the first chapter, I think, is on the philosophy of evidence-based practice. And they point out, based on 2 fundamental principles, evidence alone is never sufficient for making a clinical decision. Clinicians must weigh potential benefits and risks, inconvenience and costs of alternative interventions, and factor in client values. Oftentimes you walk out the door and you say, well, I'm a firm adherent to evidence-based practice, evidence-based medicine. They say, oh, you're just driven by research and driven by managed care. This is an important assumption that offsets that. Evidence is never enough. But secondly, that some evidence is better than others. For some postmodern folks, that is a call to battle. And this is much debated in the literature. But basically that idea is saying that some evidence is better than others. For instance, when I want to know if I am being effective, probably the best way of controlling for bias is a random controlled trial. But if I want to know client satisfaction, a random controlled trial is totally wrong. I want qualitative research. So, evidence, in their definition, is any empirical observation about relationship between events. So what we're doing is we're saying it's out there, it's something, it's not just in here. This includes unsystematic observations of individual clinicians, which can lead to profound insights but are limited because of potential bias of small sample size. In other words, this is trying to say that insight coming from your clinical practice is a form of evidence. There is an issue regarding bias that has to be dealt with when you're using it. Different evidence hierarchies are proposed for different types of clinical decisions, which is what I already said. Such as those. The people who invented this, and Eileen Gambrell and others in social work, have said this is indeed a Kuhnian paradigm shift. It's not just something evolving. It is a different way of practicing. So it's a paradigm shift, and this is what it involves. And it is very anti-authoritarian. Eileen Gambrell, in particular in Berkeley, argues evidence-based practice should be weighed against authority-based practice. Think of the audio video yesterday, the surgeon who came in. You guys didn't get to see him, but he's an older guy about my age, probably needing some sort of surgery. But he's an older guy, and he comes in and he says, based on my experience, we have to operate. You're putting your father's life at risk. We have to operate. It's in my experience, it's the best thing, and I know a study that was done 15 years ago that showed the benefits. Boy, you leave the room after that opening vignette and you say, yeah, better do it. No. The social worker working with the client said, no, we want to look at the evidence. We want to take into account client preferences and values and so forth. And that was a struggle. That's the hierarchy that's proposed by the evidence-based medicine folks. And I got to get my PowerPoint to do this. I think we're out of time. Let's see if there's any other picture that's going to be good. Additional qualities definitely that are needed under the philosophy. You need all of these usual things that we value in social work. And we need to be able to conceptualize where to get the evidence. You don't want to track down individual studies if there are good summaries available. So there's a hierarchy of where to go to get your evidence as well that's talked about, and you want to study that a little bit more. I think I'm pretty much at the end. Let's just see if there's anything else, Andre, that's terribly important here. Arguments for and against evidence-based practice. I'm not going to go through those, and that's the end of the rest, and there are many more details, but that's sort of a general overview. So I hope that worked for you and gives you a good sense. Andre, did it work?
Thank you. Yes.
Thank you.